All right. Okay. All right, let's get started. Let's grab seat and be quiet.
我先来介绍你，你再开始。Hi, please be seated. Hi, Angela. Can you ask the people outside to step in? Hello. Please be seated. Meeting will start very soon. The people on the back on the outside, please come in. All right, we'll get started. Hi, my name is Minghua Lu. I'm the managing director of eChina Health. So we are co-hosting this meeting with the USCACA, US China Anti-Cancer Association. So Dr. Li Yan, managing director of USCACA, will be the MC for this conference. Yeah, this is Dr. Yan.
All right. Good evening, everyone, and good morning, actually, for folks online. So this meeting is being broadcasted to hundreds, if not thousands, of audience in China. So without further ado, we have a very tight schedule tonight. Introduce our co-chair of this China Night at ASCO, Dr. Caicun Zhou and Dr. Li Zhang. They're going to open the meeting.
Yeah, good evening, everyone. Welcome all of you to attend China Summit Symposium. This symposium is sponsored by USCACA. I found so many beautiful ladies come to this meeting. I try to understand why up to now, and I understand because Tony has a lot of the beautiful lady fans. It's my great honor to be co-chair of this meeting with Dr. Zhang. Dr. Zhang is my old friend for more than 20 years. We work together. He gives me a lot of help. So next, I'd like to invite Dr. Zhang to make opening remarks. Welcome, Dr. Zhang.
Thank you, Professor Zhou. I'm very happy to join this meeting. This night we have either the audience from the online audience. We also have some audience from US. So it's very interesting because in lung cancer, we see a lot of changes every year. So we have a lot of new evidence and new clinical trial result was released. So it's very, very happy tonight we invite a very important speakers to tell us a new release from ASCO meeting. And hopefully this will be bring a new evidence to our patient and benefit our patients. And also thank you. We have also some panelists to discuss their own experience to share with the audience in the whole world. And thank you for your attention. Thank you.
Thank you, Professor Zhou and Professor Zhang. Before I introduce our keynote speaker, I would like to invite Dr. John Moeller from Novatech. They are the generous sponsor of the delicious food and the dinner. Not for this year, but actually for continuous support. So thank you, John.
Thanks very much, Lee. Good evening, everyone, and welcome to ASCO 2024 and to the eChina Health event, and welcome to everyone online. Novatech is absolutely delighted to sponsor this event again this year as part of our long-standing relationship with eChina Health. We've been doing this for a number of years now. We're really pleased to see so many old friends, sponsors, PIs here this evening. Novatech has continued to expand its operations over the last 12 months, particularly in the US and Europe, but also in China. And this global footprint that we have has been particularly important given some of the challenges that have been seen in the biotech sector over the last year or so. So it does go without saying that the biotech sector in China has had particular challenges over the last 12 to 18 months. Part of that has been geopolitical, and part of that has been that the funding environment has been less strong than in the United States. But it has been really good to see an increase in activity in terms of licensing activity from Chinese biotechs to and elsewhere in order to try and bridge some of that funding gap. Novatech is also supporting a number of Chinese biotechs to undertake global studies. And again, this is one of the mechanisms by which Chinese companies are trying to increase the global value of their assets. And we're very happy to help support that. And we're very well placed to do that because of our China footprint, our global footprint, but also our drug development consulting capability that helps Chinese biotechs to navigate the regulatory pathways in the United States and Europe. In terms of global trials inbound to China, it's actually been a really interesting year for us. And we've seen more US companies looking to undertake work in China despite some of the geopolitical challenges that I talked about. And we've seen higher demand than the last 2 to 3 years. So Novatech in this regard is supporting relationships between Chinese PIs to help those introductions to US biotechs that are interested in undertaking work in China. And so we use events such as ASCO to really help cement some of those relationships. And we're very happy to continue to help to do that. So again, we hope you enjoyed the dinner and this discussion and also some of the networking at the end of this event. Thank you very much.
Thank you, Zhang. Now it's my great pleasure to introduce our keynote speaker, Tony Mark. I've known Tony for, I guess, 20 years, but it seems he never ages. So let's welcome the never aging Tony Mark.
Thank you so much. It's actually quite unusual to see so many Chinese specialist oncologists in United States in one room, especially to see many family good friends, Zhang Li, we know each other for 25 years, not 20 years. So we are all getting old and getting old together and happily together. So allow me to start. Whoop, that's backward. Okay. So I was given the task to talk about what is new on ALK. So in the next 20 minutes, just focus in one area, particularly on the 5 years data that come out from Crown, which is, I think, very impressive. Then I will share my opinion in that regard. So this is my disclosure. I'm on the board of director of these 3 companies, AstraZeneca, HUTCHMED, and Incyte. So none of those companies got ALK, so don't worry. Now, let's start from the beginning. This is the one slide I show a lot when ALK first come out, when it was first discovered in 2007 by Soder in Japan in a article in Nature, talking about the fact that if it's only there's no driver oncogene. L, no. But then because of the fusion, they establish a fusion protein that become the real driver oncogene. And this is a new knowledge, but we had developed it on this concept in the next 17 years. Now I'm going to give you the update on 2 slides. Right now, we are talking ALINA, which you see a significant improvement in the event-free survival, and Crown 5 year, an impressive progression-free survival. Let's start off with a linear. Now, a linear concept is actually very straightforward and also again led by our Chinese colleague, Professor Yulong Wu, that patient with resectable ALK positive lung cancer, they got randomized to receive anatinib or chemotherapy. Now, notice that the patient going on the anatinib never received any chemotherapy as adjuvant. Now, this is actually something quite different from other adjuvant trials. And then primary and free survival. So obviously, it's hugely different with a hazard ratio 0.24, and also even in the CNS-free survival is also quite impressive and it's different at a hazard ratio of 0.22. So it's not disputable. And also, if you look at the different subgroup, mostly 2 and 3, you got a clear separation. 1B, there's a separation, but you look at the sample size, it's actually only 26 patients in total. So it's convincing, but I would like to ask the following question in your practice. First, do we really not to give a chemotherapy? I argue with Yilong this a lot. This is his study, his baby. But for stage 3, I still feel more comfortable giving a bit of chemotherapy because ALK is also sensitive to aluminum carbo. So that will be my preference, but no one can argue pro and con, it's only personal preference. Just like Chinese food versus Western food, your preference. 2 years, is it long enough? Adora, 3 years. 2 years, especially for disease with a higher incidence of brain met, is sufficient. We won't know now. The current data is fantastic, but maybe 4 years down the road, they got equal incidence of brain met, then they say, darn it, we should have to give it longer. So again, that's another point that we should have to pay attention to. The third question is a cheap question. In Alex, there's also J-Alex, 600 BD versus 300 BD. In adjuvant, can we give 300? Especially in China, I know you guys get a much cheaper drug, but outside China it's quite expensive. So can we elaborate and then take on the Japanese data into the adjuvant setting so that the patient may actually have to pay less? So that's another question. And also 1B, I still have a question mark. 14 versus 12 patient, although you got a nice hazard ratio, that is still a bit of a question mark in it. And then last but not the least is that, hey, what about lorlatinib? I mean, can you give lorlatinib adjuvant with or without a randomized study? So, I mean, it's a matter of if you see better result in stage 4, can you imply that in stage 1? But this is only a big question mark. No preference and no conflict of interest either. All right, move on to the crown. Now to the crown, I would like to just share with you my concept of what is a good drug for ALK inhibitor. Always look at the efficacy, CNS control, and toxicity, and especially on the CNS control because about 40% of the patient may eventually have brain met. Now for that, I look at progression-free over survival, intracranial response, and time to CNS progression, and also the key adverse event. So those are the data I'm going to kind of go through with you very briefly. I know that most of you are specialists, you know them quite well already, but just going to highlight what we have learned from first, the beginning. Now, Ben Solomon and I had reported first study, the Profile 1014, a Pfizer product at that time, a star product because that was the first one demonstrate efficacy in 2014 and demonstrated it's better than chemotherapy. And then in about the same time, Ceritinib had done a similar study, the XN8, and then also demonstrated improvement over the chemotherapy reported by John South Soria. However, outdated. So it's good study for the start. But basically, I think I will have to put the 2 on the side, given the new development of the drug. So in my table, I think I have to cross out these 2 agents for the time being in the first line. Anatinib, brigatinib, and enzatinib, which is only in China, and lorlatinib. And for that, we have 4 randomized studies. So I'm going to focus mostly anatinib, brigatinib, lorlatinib, because those are the ones that's available internationally. Okay, so I mean, if Beta Pharma invite me to talk, I'll include the enzatinib, but this is sponsored by Pfizer, so I'm not going to talk about that. So, putting all those data together, you will see that one thing that's in common is that all the stratification factor has to include the CNS, which is important. Yeah, so no good study on ALK would ignore this stratification factor because with or without brain met would make a major difference in the outcome. The rest, I think, is less important, but this is the key one. If you also look at the patient data, this is a busy slide, but don't look at the detail. I just want to show you that Asian account for about 40% across the board in all the study. But then the brain met is about 26% up to about 42%. In the Crown study and the Alta study, this is about 30% or so, which is about the same. But then the addict study, we actually have high incidence of brain met. One of the reasons is that at the early so-called baseline, everyone had MRI, and the MRI tend to pick up a little bit more brain met than using the CT scan. So that accounts for one of the reasons why we see a little bit more brain met in the addict study. So looking at it, let me just walk to this side since I have not paid attention to this side of the thought. So we are looking at the second generation versus the third generation drug. I have to admit, over the past 5-6 years, and blaming on Alex, that there's actually more incarnation of the second generation drug. The early data that come from the Crown study did not change people's behavior. United States right now, I think the market share of Loratadine first line is only about less than 20%. So there is incarnation on the second generation drug. And this is well justified if you look at the efficacy, CNS, and toxic data before 2023, okay? But today is 2024, but before 2023, you got this incarnation. Why? Well, look at those data. It's quite relatively convincing on the brigatinib better than crizotinib, as well as enzotinib better than crizotinib, and in addict study better than the crizotinib, with the median progression-free survival about 34 months for anatinib and about 27 months for the brigatinib. So that's clear. And then in terms of overall survival, I reported that the 5-year overall survival rate at 62%, which is quite good, meaning that 2 out of 3 patients that walk in my office, 5 years later, they're still alive. They may have progression, but they are still alive. They may be on other agent, maybe on chemotherapy, but they are alive. So that is actually a good data for patients with lung cancer in the, especially before we have the oncogene-driven lung cancer knowledge. And then for the Alta-1 first line, there's overlapping in terms of overall survival. The reason is that there's a lot more patient was allowed to cross over, also in trial and outside trial to another TKI. So as a result, the crizotinib receive it, and therefore the overall survival is no difference. So I think that explains the data quite well. In terms of the brain, the response rate is quite good. Intracranial response rate about 66% and 59%, which I think is adequate, in terms of that. And also as a result that you demonstrated at 1 year, that ALEX study, their CNS progression rate is about 9.4% compared to about 41%. However, let me tell you one thing. Rosa did a good study with ALEX, but they kind of look at the budget a bit tight. So they stopped doing MRI after the first year. So not every patient routinely get MRI if there's no CNS evidence of CNS progression. So therefore, they were not able to produce the data that you're going to see about from the Crown study. So with that, there is also the comparison toxicity, generally well tolerated, some liver toxicity, as well as there are some edema, some weight gain, but not too bad in terms of toxicity of this free agent. So that is on the second line. It's a second generation drug. And with that, we have to focus now on what happened in 2024. Now, of course, the Crown data is not 2024. This study is similar to other 296 patients comparing loratadine with crizotinib and looking at progression-free survival endpoint. The first data was published in New England Journal of Medicine by Alex Shaw, showing an improvement in the progression-free survival, but that is back in 2020. Now, but with that, there is another follow-up 2 years later in 2022, published in 2023. Ben Solomon reported this at 36 months. And now the key thing is this. Number one, the hazard ratio is still maintained at 0.27. Now the other 2 agents, second generation, hazard ratio is about 0.45 and 0.48. Now, and this is but we should never compare hazard ratio. I always tell my students never compare hazard ratio because a ratio should not be compared with a ratio. But one other thing is important is that at 3 years, the progression-free rate is 64%. Now, it's actually quite a reasonable data. given that, the so-called the median has not been reached. But it does not give us a conclusion that for this to be better, there's a second generation drug. Because the data is suggestive that it may be better, but you cannot conclude that it is better. So now come yesterday that Ben presented the 5-year data. My name is kind of in the middle, I don't care, so. But now I have to say one thing. This is a post hoc analysis. Let me explain. 3-year is a planned analysis. We want to have the data at 3 years. And then after that, we see, it's kind of nice. We're sitting on steering committee and then debating what to do. Well, we say that, hey, 3 years good. Let's take a look at 5 years. But then 5 years was not planned. So therefore, we call it a post hoc analysis. Now, usually among academic, we kind of a post hoc analysis. We don't put a strong emphasis on post hoc analysis. Doesn't think that it is a planned scientific data. But this is a little bit different. In a way, is that we planned this. We cannot plan this because we don't know what happened at 3 years. But once you look at the 3 years, it's only natural to ask the question, what will happen at 5 years? Now, we maybe after this, we'd ask the question, what will happen at 7 years? But let's stick at 5 years for the time being. And so with this, that we have the data cut off at October 2023. This is the result. Now, first, we have emphasized on the fact that the median has not been reached. It's quite clear. Now, we have 64% before, now at 5 years, 60% still, if not reached it. And then the hazard ratio is even better at 0.19. So in a way, is that with the longer duration of follow-up, you're actually seeing better data. Now, one other important aspect of the fact is that at 5 years, you have the progression-free at 60%. If you project what the median should be, the only logic is that it has to be over 60 months. There's no other way. It can't go back. It can go forward. So you know that the median progression, when you reach it eventually, with another 10% of event, when you reach it, has to be over 60 months. So in other words, it doubled the median progression-free survival at inetinib. No other way out. So when you see something that's double, although it's not a head-to-head comparison, but we know the patient characteristics are quite similar, then it's actually a striking information for most of us that we're double the progression-free survival, which is never heard of in lung cancer. Now, 60% versus 8%, and I think there's again a very striking difference as well that we have to pay notice of. Now, one other interesting fact. I just told you about the ALEX over survival data. At 5 years, 62%, but progression-free at 5 years is 60%. We're comparing progression-free survival in this incident. So I'm not saying this because Pfizer invited me to, but it's just looking at these two curves, I just say, this is outrageously crazy. All right, subgroup. Basically, you see all these data that in a subgroup, you expect that to happen. But actually, I want to show you one thing for people who like to play around with statistics. Look at the upper margin. I mean, we're not looking at the hazard ratio. The upper margin of the 95 percentile CI is looking at 0.3 to 0.45. Have you ever seen things like that before? I haven't. To be able to have a upper margin in such a low hazard ratio, that is, again, data. All right, let's go to the brain. Now, the brain, of course, you know that is still well divided, but I want to point to one thing. So with the brain met, okay, that you still have about 53%. The patient, again, had not reached the median progression-free survival on the patient with the brain met. And also patient without brain met has not reached the over survival. But another point is this, crizotinib. Now, with the brain met, within 2 years, every patient progressed. This is the message, touching the bottom. Now, most of the time, they don't touch the bottom, but if you are ALK positive, you got brain met, you go on crizotinib, 2 years, guarantee you to have a progression, 100%. That's another important bit of data that we can learn from other data source. Now, let's go in a little bit detail about the time to CNS progression. Again, this is for the fact that they do the damn MRI every 8 weeks. 5 years every 8 weeks, that's over 40 MRI. $5,000 per MRI, you calculate the money they spend on it. I mean, 5,000 is only American dollar. I mean, in China, it's only about $300 for MRI. But still, 92% of patients are progression-free in the brain at 5 years. Only 9 patients have progressed. Now, for us as a scientist, we ask, say, who are those 9 patients? Why do they progress? Okay, so that's why you had looked into the greater detail of this one. On the patient with the brain met, actually 5 patients. And then patient without the brain met, 4 patients. So they're actually quite equal. Not the patient with brain met progressed, but there are a few patients without brain met also progressed. So it's not so much tell me one thing is that it's not thing to do with the penetration of the drug. It got to be some mechanism. And also interestingly, if you see the graph, most of this progression occur early. So that has to be genetically certain that we have not clear what yet, but genetically, they are actually the one who have the progression. And again, I want to show you the fact that at patient with brain met, most of them progress. So in other words, the overall progression, at 2 years of crizotinib, most of them actually attributed to the brain met. All right, but there's another interesting aspect is that question is whether the dose reduction is going to be different. What about variant 3? What about TP53? We will all want to address those questions. So dose reduction is common because there is toxicity. And then, so the patient with the dose reduction, we actually look at the progression-free survival. The solid blue line is the one with the dose reduction. As you can see, it's actually not inferior. Anything is slightly better than the patient without dose reduction. So in other words, it is okay to dose reduce, and then you may still be able to attain a similar kind of expected progression-free survival. Now, variant 1 and 3. Again, you see the 2 separation. The solid line is 1, and then the dotted line is 3. And you can see that they are actually similar. So in other words, whether variant 1 and variant 3, it does not make any significant difference. There's not even a prognostic value in this regard. But then on TP53, then it is actually prognostic. You can see that there is a separation between the solid blue and the dotted blue. But then it's overall still better than crizotinib. So in other words, TP53 cannot be used as a predictive factor, but it's prognostically worse. Last but not the least is that actually, would it affect the mechanism of resistance? Because it's important, because the fact of this is that if you give a drug that you're going to cause you more difficult resistance, so at the time progression, you may be more in trouble. The OS may be affected. So we looked at the selective sample from the blood mostly. And interestingly, on the lorative arm, we only got 31 patients that had progressed. 0 got ALK-dependent mechanism. As compared to crizotinib, you actually have single mutation or compound mutation. G1202R is one of them. Now, I have to give you one word caution. This looked fantastic that, hey, 0 ALK-dependent mechanism. But some of the progression can be at low volume, such that the ctDNA cannot detect it. So the 0 may not be 0. So don't get deceived entirely for it. But then the message is that fact that maybe we actually clear off any ALK-dependent resistance. Most of this resistance is actually on the bypass pathway, MAP, PI3K, and RTK. But most of the patients are actually unknown. So still a lot of work to do, especially in China. You can sample and pick anyone and NGS everybody, So this is actually the time to look for more mechanism in this regard. Now, toxicity-wise, signal, cholesterol, cognitive effect, and then some GI toxicity that has to be managed. This was actually had a simultaneous publication in JCO. Now, we do not have a slide, but you want to ask one question. I have high cholesterol. Does it lead to more cardiovascular event? And in the manuscript, you read it carefully. we look at the 5-year cardiovascular event, there's no difference between the lorlatinib and crizotinib. As a matter of fact, a slightly higher incidence of the cardiovascular event in the crizotinib arm than the lorlatinib arm. But take a look at the thing. So in summary, I think there's a great advances in the ALK in 2024. And then in the early stage, linear is the stage, but there, we still got a few questions related to the dose and the duration and stuff like that. And then for advanced stage, I think the current 5-year changed the paradigm quite a bit. So we have looked at the lot reached at 60 months. The 5-year progression rate is actually 60% versus 8%. There's also the time to CN progression differences, and also the dose reduction do not change the efficacy outcome. Variant type doesn't matter. It's neither prognostic or predictive. TP50 is prognostic, but not predictive. So all this information, I trust when you go back to China, it will change your practice. So this is the conclude my talk. And what am I looking forward to in advancement is actually the dinner later on in Chicago. Thank you so much. Thank you.
All right, thank you, Tony. Thank you so much. So Tony has set up a really good stage for the panel discussion. So now I'm going to invite. Okay, all right. Okay. Yeah. Okay, sounds good. So I'm going to invite to the co-chairs here and also the 4 panelists. Oh, still the steak. Oh, the steak stays here. All righty. All right. So co-chairs and our panelists, please come here to the stage and we're going to have a discussion about the lung cancer.
Yeah. Dr. Fang could not available for this meeting. So we like to invite Dr. O up to stage. Dr. O, welcome, Dr. O. That's your seat. So let's start from the Dr. Wu. Okay, Dr. Wu.
I'm so nervous. Yeah, I checked some notes about the answer. Yeah, we have 3 questions. Maybe I can initial on the first one. Yeah, I checked some notes. Yeah, what specific aspects of data for the updated progress of all positive advanced non-small cell cancer impressed me the most? I think maybe the in terms of the primary endpoint and PFS, median PFS has still not been reached, and the PFS rate was as high as 60%. That impressed me the most. That means more than half of the patients can have durable and deep response from lorlatinib in the 5-year, which corresponds to the longest PFS in advanced non-small cell lung cancer. We called ALK positive ALK mutation as a diamond mutation. So I believe that the diamond it will be shining more brightly if it put it inside the crown, so looks brighter. So that's impressed me the most. Thank you.
So you say that you give the diamond to the ALK oncogenic driver. The diamond should be in your ring, right? The husband to wife. So I do think that the ALK fusion is not diamond, it's oncogenic driver. We wouldn't like to say that we have diamond drug, right? It's better, right? Doctor.
I think before I hear about the updated data for the Crown study, in fact, in the past, when I see my patients with stage 4 ALK positive non-small cell lung cancer, I would explain to my patient that based on the Alex data, if they were being put on the alectinib, in 5 years' time, they've got a 60% of chance of still surviving.
Yeah.
Now, with the updated data of the Crown study, what I'm going to explain to my patient is if it's being treated with lorlatinib in the first line setting, then you got the 60% of those patients will not need to change the drugs in 5 years.
5 years, right?
So that's what the impact that I've got from the updated Crown study.
So may I ask you a question? Lots of people may be seeing in different way, if you treat your patient with first-line alectinib, when the patient develop this question, they can treat with lorlatinib, The first-line alectinib, second-line lorlatinib, maybe overall survival is same.
That may be true, although I guess it's looking at the Crown data, it's probably not. But if I were the patient, I would not want to have disease progression.
Okay.
Because sometimes the disease progression is highly unpredictable. It could be causing a lot of morbidities. So, and also, in fact, you run the chance of not able to have the second line treatment. So that's always a risk to take.
Yeah.
Yeah, just in line with the host comment, I don't think there will be a second line PFS for more than five years. So I don't think patients should take any risk to take this medicine in the second line. So it just think about data. The data itself is exceptional. Before this update, I don't think we can remind ourselves about any data from solid tumor advanced stage to achieve this kind of level. This is the next level. So actually, so I would say this presentation has already made impact in this meeting, because actually I came to attend this meeting. Before that, I will attend a educational session which talk about CNS metastasis, and they just quote the updated Crown data as part of the presentation, and try to emphasize the right treatment for patients with a drug mutation. So take it as a whole, I think the achievement to achieve a PFS rate above 50%, above close to 60% at 5 years, you had to be. I mean that the medication have to be very potent in every aspect. The response rate to all the existing lesion, and the prevention, the ability of prevention for the all existing lesion, and for those potentially bypass the lesion or mutated remuted lesions. So this is a very. I don't think it's the end of the history, but I think it's a new chapter. It's so just like what Dr. Churchill, not Dr. Churchill, Winston Churchill says, it may not be the beginning of the end, but it could be the end of the beginning.
Okay, great. Dr. O.
Yes, we have Professor O joining us because Professor Fang is already cannot be attend this panelist. So Professor O is also a specialist for org. They have to do a lot of clinical trials, and he will join us for our panelist.
Yeah, my whole purpose here is not to crash the party. I want to introduce my fellow who is turning to be attending in 2 months to all the forensic power in China. You know, Professor Zhang, Professor Zhang, Professor James O, and of course Tony Mock. I'm not sure she's stuck in traffic. I mean, I can add also the resistance mechanism is pretty impressive. There is no on-target resistant mechanism. So that's one of them, plus the others. You know, we have to give credit to Professor Zhou Chuishi. You know, he did the Alicia trial. There was one still, you know, before this day was the longest in PFS, almost like 43 months, 42 months. So I think the resistant mechanism is very interesting. Nobody has found any on-target mutations yet. And the long PFS, the brain control, the variant-free and TP53 mutations. So all these are very good. And I think the key is number 3, the patients and the clinicians. So it all depends on the funding mechanism for the patient. So if you are taking this for 10 years, how is the financial impact and in the US it's fine. We just get, pay. And if the patient needs assistance, they apply for Pfizer annual assistance. I always remind my nurse in November, make sure they fill out the form so that I can sign it. So that's the more practical matter is you have to take this drug potentially for 10 years.
So I have some questions for the panelists, which is from my opinions, talking about the mechanism of the lorlatinib. Are you changing your post-lorlatinib treatment because there was no ARC dependent resistance? So how about your post-lorlatinib treatment? Will switch, or what about thinking about the post-lorlatinib treatment? Dr. Wu.
From Tony's talk that we can see the resistant mechanisms was focused on bypass mutations and the other gene mutations, but not ARC resistance mechanisms. So maybe we should need some like MAPK, like that kind of therapy, targeted and that kind of genes, and maybe some like chemotherapy. And I think there are many researchers and scientists here, so we can collaborate to have some further research about the further treatment for these resistant patients. Yeah. And I also have a question, maybe behind this question, we can discuss about it. If the patient have good response to like alectinib, and she's not PD status, yeah, then the patient may ask us, yeah, I saw the results of the 5-year data. Can I change the drug to lorlatinib? And what's your opinion? Thank you. Dr. O?
So it's another question that I'm trying to ask you guys, the panelists, but right now you raised these questions earlier. So we will see the other panelists' opinions. Do we need to switch the lorlatinib from right now other TKI treatment?
Well, my simple way of handling this is that I'm sure everyone would recall, you will have a handful of patients who, with the EGFR mutant non-small cell lung cancer, who benefit from even first generation EGFR TKI for 10 years, more than 10 years, and they are still on first generation EGFR TKI. I think it's something that we do not know yet in terms of the tumor biology, who may actually benefit simply just from a first generation EGFR TKI. For the same token, if someone who is doing extremely well with alectinib I've got little reason to switch.
So actually, for the first question, that's exactly bothers me because actually 2 years ago, I asked Dr. Solomon Benjamin about Benjamin Solomon about this question. If we look at the PFS curve, at 5 years, approximately 40% patient progressed or recurred. However, 30% of them recurrence occurred during the first 2 or 3 years. So what is the mechanism of that recurrence is very important. So just now, Professor Zhang bring this out. So now I think maybe chemotherapy with anti-angiogenesis could be our first choice. I really don't know. And however, the sample itself is very important because we also see other mutations or could indicate another TKI focus. So I don't know at this point what is our best strategy. However, I think we should bring more tissue, try to figure out the mechanism, and then we can put together all the data and know better about this question. For the second part, actually, I asked myself about this question a couple of times because I prescribed a pretty number of lorlatinib for my first line patient with first line treatment. However, the problem, I'm not sure what happened here in the United States, but for my daily practice, the high cholesterol level is quite a problem for me. It's quite bothering me. I'm from a cancer institution. I don't have any other physicians which can help me at this point. So I have to refer them to other institutions. And some of the test level is quite high. The internal medicine doctors have to prescribe antibodies to question. I know just actually Tony just high after 5 years there's no cardiac vascular related complication, and there's no indication, there's no sign of increase of any cardiological events. I actually buy in this his data, but I still think we will have to work very hard to control this side effects. So for now, I will do it just like Professor Ho just mentioned. I will do it very carefully. I have to give a good reason for my patients and for myself to switch to another treatment. Thank you.
Professor O.
So I'm a little bit more absolute. If you started alectinib within the last 6 months, I would switch. 9 months, maybe. I think you have to look at the response to alectinib. Was the tumor burden very high in the beginning? Was the primary mass 5 centimeters that shrank to 3 centimeters? Versus if they have a very good response on alectinib. I do measure CEA. I've gone back old school and measured CEA on everybody who started. So I also look at the CEA level. The CEA did not drop as well. The tumor burden is high to start with, and it was mostly stable disease, minimal partial response. I would probably still, 1 year is hard because if you switch and they progress, then that's not good. ctDNA, I do it. If ctDNA is still positive after 6 or 9 months of alectinib, then that's definitely to switch. So then, 6 months, I'll definitely switch without seeing a lot of measurement. After nine months, I have to explain to them why I switch, why I think alectinib is not as good. The tumor burden, the CEA, ctDNA, all of them will play in a role. And also how old the patient is. If the patient is pretty young, then I would definitely switch
more inclined to switch than, let's say, somebody who is in their 60s. You never know. Once you switch and they progress, and then it's bad luck. And so.
Let me just address this point, because actually we discussed this in the Crown Steering Committee about this switch question. So first of all, if we want to switch, we have to generate some data. So if there's no data, by just your own intuition, I think it's hard to justify. Given the fact that lorlatinib does have toxicity. And then if it doesn't have the toxicity with imatinib, you switch it to a drug with toxicity, we need the data to back us up. So I think right now, the first question for this study is that, what is the time? Just as you just say, should it be 6 months, within 6 months or within a year that we can do this switching? That's number one. And number two is that if we're going to do the switch, then what should be the primary endpoint? You know, and how do we quantify the endpoint so that we can know that it's actually going to be better off? So at this stage, without the information, I would not. So my general principle, if your husband and wife is serving you well, don't get divorced.
Okay. Okay. Thank you. Thank you, Tony. Thank you, Tony. So I think the final questions to the panelists is there. Given that Tony already showed us the adjuvant evidence of the ARC inhibitors, are you comfortable to use the lorlatinib as an adjuvant setting? Or do we need another new clinical trial?
Before the 5-year data, I think it's no need. But after the 5-year data comes to us, I think maybe we can try it. But the toxicities is a very important issue for us, because it's totally different from China and US. I'm now as a visiting scholar in Stanford School of Medicine. I together with Professor Wickley, like a doctor has many people to assist a professor, like PA, like nurse, and like a social worker. But in China, one doctor, one team. So it's very difficult for us to manage so much toxicities. So that's why I'm more worried. And I think maybe we can have many educational lessons for a class for the patient, and maybe the social, we need more social workers to assist doctors and patients to solve this problem. So that's all, yeah.
So maybe we can continue, but we do not have enough time. We like to stop here. Thank you very much for your excellent discussion. We have second panel, okay? Thank you.
Well, thank you for the panel discussion. That was really great. The reason we have to cut short is so that Tony will get his steak dinner, right? Oh, all right. Good. All right, go. Thank you, Tony. So now we're going to invite, well, congratulations to Pfizer, developed all these wonderful drugs. So we're going to hear from Dr. Rao from Pfizer, what they are doing for the future generation of new drugs globally for all patients.
Thank you so much. This is the slide, okay. Okay, thank you so much. Okay, I couldn't have asked for a better presentation from Tony. I promise you I didn't tell him to say any of these things, so I'm thrilled. And I don't know if Dr. O is still here, but for those who don't know, Dr. O and I trained together in residency at Duke. So we go a long, long way. He's very young. So we trained many, many years ago, and we were on call many nights at Duke University. So it's very nice to see him. And he's always been such a good advocate for lorlatinib. It's just wonderful to kind of come full circle as we grow older. I am the Vice President for Late Stage Development, and I kind of run the thoracic oncology portfolio under Roger Dancy at Pfizer. And so I will actually skip through a couple of the early slides from lorlatinib just in the interest of time, because I have a lot to cover over here. I'm going to quickly, My bad. I'm gonna skip through all of this. You all know that lung cancer is a major issue in Asia, especially in China, where almost half the cases in the world come from China. It's 20% of cancer deaths are all because of lung cancer. And then when you add head and neck tumors, which is also comes under the thoracic portfolios, that's also a major issue in Asia. I'm going to skip through this too. You know this. Most patients present with late-stage disease. We see EGFR ALK mutations in higher numbers, at higher incidence in China and in Asia. And so I just want to point out that in the early clinical and preclinical pipeline, now at Pfizer, after the acquisition of Seagen, we have a number of ADCs, biologics, and multiple small molecules that are all under development. I will kind of touch on some of these as we go forward. We are an industry-leading ADC portfolio. You can see from left to right over here that we have 4 approved vedotin ADCs. We have a number of vedotin ADCs in development. I will talk to you about sigvotatug vedotin, or which we call SV at Pfizer. This is a B6A or integrin B6 ADC with a vedotin payload that we're seeing some really nice signals in non-small cell lung cancer. We have a topo-1 payload with CEACAM5 and some other drugs. And then we have some next generation payloads with PROTACs, with TLR7/8 and a bunch of other things going on. So we really have a massive ADC portfolio at Pfizer. I'm going to quickly touch on B6A, the PD-L1 directed vedotin, the CEACAM5 directed topo-1 ADC, the EGFR targeted bispecific, which is a gamma delta T-cell engager, unlike the classic bispecifics that you see so far, which have been alpha beta T-cells. This is a gamma delta T-cell engager. And then finally, we have a pan-KRAS inhibitor. I'm going to skip through Lorbrena because I couldn't have asked for a better presentation. And in the interest of time, I will skip this. So I'm going to go straight to sigvotatug. I don't know if folks had a chance to go to the presentation this afternoon where we presented the data at the rapid oral presentation. But essentially, SV or sigvotatug vedotin is our IB6 ADC. IB6, which is integrin beta-6, is overexpressed in a large number of solid tumors. You can see in the graph over here that several tumors will express IB6. It's also overexpressed heavily in lung cancer, both in squamous and non-squamous. What I like about IB6 and our antibody is it's a very, very clean target. So typically integrins, beta integrins and alpha, the beta units and the alpha units will pair up very promiscuously. IB6, so beta-6 only pairs with alpha V, and that makes it a really clean target. And this antibody that we have is basically only against IB6, and that's why we don't see any off-target toxicity. It has the same protease cleavable linker and the MMAE payload that we have had for all our vedotins, and the DAR for this drug is about 4. The phase 1, we've dosed over 320 patients in multiple solid tumors, all the way from esophageal, melanoma, lung cancer, head and neck tumors. And what I will be presenting to you is just the non-small cell lung cancer data. Part A was the dose escalation. Part B, which is ongoing, is disease-specific expansion cohorts. 117 patients with non-small cell lung cancer were dosed in this phase 1 dose escalation. Median age was 65 years, heavily pretreated with prior platinum and with prior checkpoint inhibitors. We learned a couple of things in the phase 1. The dose that you see that is active in most of our vedotin drugs, I will point out that you will see activity, anti-tumor activity at about 1 milligrams. Before that, you don't really see any activity. So we began to see responses at 1.2 mg per kg with this drug. And we thought that was going to be the dose because we were doing total body weight dosing. Then we found that patients who were under 60 kilograms actually had a low response rate because they were actually getting less drug based on total body weight. In the same token, patients who were heavy and over 80 kilograms, we were seeing a little more toxicity. Finally, when the PK team looked at the drug variability, we found that patients who received 1.8 milligram per kilogram, day 1, day 15, adjusted ideal body weight, had the best exposure and drug, steady state drug in the periphery, in the peripheral blood. And so keeping that in mind, this was the dose that we took to the FDA and the EMA, and this is the dose that will go forward in all of the phase 3 studies now. So as you can see over here, the efficacy is in the green is all of the non-small cell lung cancer, but the column to pay attention to, and I'm pointing out on the screens over here because I'm naturally turning towards the right, but the blue column here is the non-squamous taxane-naive patients who had a response rate of 31%. What I want to point out importantly is that we did see 2 complete remissions in this population, even in the phase 1, which is, I think, really important in non-small cell lung cancer because complete remissions do matter. And so you can see that we had a fair number of stable diseases, and the duration of remission right now is about 11 months. You can see over here that some of the patients on these forest plots are hanging around, have received treatment for almost 30 months. Some have been around for 20 months. And so we are seeing a nice duration of remission with this drug. If you focus on the blue graphs over here on the left-hand side of your screen, those are your non-squamous taxane-naive patients. The median progression-free survival was 6.4 months, and the median overall survival thus far has been 16.3 months. I want to point out that if you were to compare with, for example, Daiichi and AZ's drug Dato in the first line in the phase 1 and in their big phase 3 trial in second line, the median PFS was 5.6 months in non-squamous patients. So this drug in the phase 1 is giving us a median PFS of 6.4 months. This is the study right now. We are dosing a biology cohort and collecting samples. We are also doing a non-small cell lung cancer docetaxel naive cohort, because really the question that I have is it a histology issue, or is it a payload issue, or is it a taxane exposure issue? So we want to look at a cohort of patients that are docetaxel naive, and so look and see if these patients actually have a good response to the drug. We've also begun the combination of patients of SV plus Pembro. We've dosed 7 patients so far with sigvotatug plus Pembro, and it's looking really good. And I'll show you some nice preclinical data on this too. This is a safe drug. It's a really clean target. We are seeing the toxicity that we see with this drug is very typical of what we see with vedotins. You see peripheral neuropathy, you see fatigue, you see some cytopenias, but nothing that is out of the ordinary. So if you were to pay attention to just the 1.8 mg per kg, which is the dose that is now approved by for the phase 3 studies by the FDA, you can see that the number of grade 3 treatment-related events is about 16%, but the number of patients who come off of the drug because of the AEs is less than 10%. And the number of patients who, in the 1.8 milligrams, there were no patients who died because of treatment-emergent AEs. If we were to pay attention to some of the very prominent AEs that have come up with the other ADCs right now in the market, what I will tell you is, again, on the right-hand side, if you were to pay attention to the blue column, which is 1.8, you can see that you see fatigue, you see peripheral neuropathy and nausea. Again, typical vedotin-related toxicity that we have seen over the years. But if you look at some of the actual adverse events, you look at, neutropenia or stomatitis. Stomatitis is a really big issue with Dato. Pneumonitis, we saw all grade pneumonitis in the entire group. There were only 6 patients. In the 1.8 milligrams, there is no pneumonitis. There was 2 patients who had grade 3 or more pneumonitis, ILD. 1 patient at 1.25 milligrams passed away from their pneumonitis. This patient was heavily pretreated with 2 prior checkpoint inhibitors. And so this is not unusual in somebody who's that heavily pretreated. But overall, IB6 is a really nice, clean target, and we're very happy with how nice this profile is looking. I will also remind everybody that there are 28 HER2 ADCs that are right now in development around the world. There are 16 TROP2 ADCs around the world that are being developed. We are the only IB6 ADC right now in clinic, and we really, really like how clean this target is and how good the data is looking. This is the phase 3 study that is ongoing right now. It's called the B6A002 study in the second-line setting, locally advanced, unresectable, metastatic non-small cell lung cancer, non-squamous histology, will be randomized 1:1, 600 patients, either to sigvotatug 1.8 mg or docetaxel 75 mg per meter square. The primary endpoint is a dual endpoint of PFS and OS. I'm going to quickly run. I got my 2-minute warning over here. I do want to point out that the China study, we expected to dose the first patient in August of 2024 at the same 1.8 milligrams. So please be, the study is now, Dr. Zhou and a couple of other folks are going to all dose patients on the study. And the next steps, of course, are to look at the first-line setting in the more than 50% TPS score of more than 50% with Pembro, and also in the all-comer study in combination with chemotherapy. The triplet of SV plus Pembro plus chemotherapy is going to start next week. I also want to point out one very important piece that I always point out when I do these talks is that we have a lot of data at Seagen, when we were at Seagen and then came to Pfizer, that vedotin ADCs induce ICD, immunogenic cell death, much more robustly than an ADC that has a topoisomerase 1 inhibitor. And we have beautiful data in the preclinical setting from our research scientists looking at what happens when you put a topo-1, like a deruxtecan or an exatecan into cells, and what happens when you do a vedotin. And what ends up happening is that our payload really induces a very active TME. It brings in macrophages. It increases cytokines. It causes PD-L1 to get upregulated. And that leads to a better response when you combine it with Pembro. And this is proof in the clinic. What you see in the clinic, anytime we combine a vedotin with Pembro, whether we have combined Adcetris, whether we combine enfortumab in bladder cancer, whether we combine Tivdak or disitamab, we are seeing higher response rates when we combine with pembrolizumab. So we are very hopeful that when we combine SV with Pembro, we will see the same high response rates. There's a whole bunch of phase 1 studies that are ongoing. I do want to point out our PD-L1 ADC. This PD-L1 antibody is combined to a vedotin payload. This is not a checkpoint inhibitor. This is a vedotin ADC. The PD-L1 is a very small homeopathic dose. It internalizes very rapidly into the cells, much better than avelumab and atezolizumab, which are your commercially available PD-L1 antibodies. This is the phase 1 design where we've completed dose escalation. What I will tell you is this is a really safe PD-L1 drug, PD-L1 vedotin. We have seen no DLTs, no horrible neutropenia or peripheral neuropathy. Most importantly, we have not seen immune-mediated events when we have this PD-L1 antibody combined with a vedotin. So we are now exploring this in head and neck tumors and in non-small cell lung cancer in the expansion cohorts. CEACAM5 is the other drug that we have right now. It's with a topo-1 ADC called 7192. This is a really strong topo-1. It internalizes very rapidly. It's very, very permeable, and it is resistant to drug efflux. So it sits around in the cells for a long time. And this is a PDX model that I want to show you. On the left-hand side is CEACAM5 with deruxtecan in the 11 lung PDXs. And then on the right-hand side is our PD is with the topo-1. And you can see that, yes, with deruxtecan, you do see some responses, but with our topo-1, you see complete responses. So we're very excited to see how CEACAM5 is going to do in the non-small cell lung cancer setting. This study is right now ongoing. Also, we're dosing patients with CRC, gastric cancer, non-small cell, and with pancreatic cancer. And we're very excited to see how this, we're really hopeful that CEACAM5 may finally show something with this payload, because there've been some disappointments recently with Sanofi and with Gilead. Finally, this is one of my favorite molecules in phase 1 right now. It's an EGFR-targeted bispecific gamma delta T-cell engager. We licensed this from a company called Lava Therapeutics in Netherlands. This is a really special antibody. It's a VHH recombinant nanobody that we can get from immunized llamas and camels. It's a camelid-derived antibody. What's nice about VHHs, as you know, is that they are so small, they're highly soluble, they penetrate really well, they go into the nooks and crannies of the tumor, and so they really can kind of get to the tumor very nicely. What that then does is that it engages the gamma delta T cells, And unlike alpha beta T cells, which lead to really high levels of cytokine release syndrome and ICANS, with gamma delta T cells, we do not expect to see that much of ICANS and CRS. So I'm very excited to see how this is going to do in the phase 1 setting. The phase 1 is currently ongoing in EGFR tumors like CRC, non-small cell and head and neck tumors. And we've dosed about 7 patients right now, so we should have some data coming up. And finally, the pan-KRAS, I'm going to stop, I promise. Finally, the pan-KRAS inhibitor that we have, PF4040, which is our pan-KRAS inhibitor, engages the on and the off stage of the KRAS. And so not just the on, but on and off stage. It inhibits all of the mutant alleles approved, unlike G12C inhibitors alone. It spares HRAS and NRAS, and therefore it has a better safety profile. And so, as you can see over here, when we compare our pan-KRAS inhibitor to some of the other drugs that have been approved or that are being developed, you can see that we have a much higher potency and really good anti-tumor responses. And we have a phase 1 trial. This IND just was submitted to the FDA about a month and a half ago. We expect that we'll dose our first patient in dose escalation in pancreatic, CRC, and non-small cancer in about 2 months as soon as the IND clears. We're very hopeful of this. So I've covered a lot. I'm very sorry for going this fast. What I want to impress on you is that Pfizer really has a nice portfolio for you when it comes, whether it's not just ADCs, it's got small molecules, it's got protein degraders. We have some really nice bispecifics and immunomodulatory agents. It's a very large group of drugs. In fact, in the preclinical setting, in research with the chief scientific officer, we have 63 different molecules right now that the lab is working on. So it's really exciting time for us at Pfizer. We're very excited. I do want to point out that the lorlatinib first-line data we are very happy about. This is game changer for ALK-positive non-small cell lung cancer. And then, of course, the B6A ADC has some encouraging activity, both in non-small cell, head and neck, and we're hoping to expand this into the first line and the second line settings in combination with pembro and with chemo as time goes on. So with that, I will stop. And I guess, do I take questions or? Yeah, we'll wrap it up. Okay.
Yes.
Thank you for your time.
Well, great. Thank you. Thank you, Dr. Rao. Thank you so much. And your passion and your commitment to oncology just passes through to everyone. So thank you so much. Yeah. Great. Thank you. Yeah. All right. Now it's really exciting for me to really very briefly introduce our organization, the U.S. Chinese Anti-Cancer Association. We've been in operation for 15 years, really serving as a bridge between U.S. and China. And today, we're only going to talk about one thing, the awards. We have 3 different categories of awards. One is a travel award. These are for young investigators coming to U.S., attending AACR or ASCO. Second category is Young Scholar Award. These are, again, for young people, for the next generation. Third one is Effort. These awards will sponsor young investigators coming to U.S. to get trained, especially in the early phase 1 studies. So today is my privilege to actually introduce 4 recipients for the Travel Award. But every award is, actually the award is $1,000 per person. So we need a sponsor to pay for the award. So today we want to really recognize the donor of the year of 2024, my neighbor, my dear friend, Dr. Song Li, who is a founder and the chairman of Frontage, which is a very good CRO. But he's not here, but we still thank him for giving us a big donation. So. So we do have 4 recipients. So I'm going to invite all 4 of you come here. Come here. Qi Changsong, Li. Come here. All 4 of you, Liu Wei. Yeah. Come here. All right. I'm going to invite all 4 of you coming here. So we got. All right, just line up and. We're going to, okay. All right, well, congratulations. Yeah. And we do have a certificate and a check. So We got checks. So the first one is,
100.
and where's the, okay, all right. So it's $1,000 and so the certificate. So congratulations.
Thank you. Thank you
All
very
right.
much. Yeah.
All right, we'll take the certificate. All right, so next one, no, you're going to present. No, actually, no. No, you present the second one. Actually, you present the second one. No, come here. Because that's your medical school, so. So the reason I presented to the first one is we graduate from the same medical school, so, yeah. So the second recipient is from your medical school, so you present. 哦，这个不给他了，因为他没来。
We honor his award, but without a check. So that's fair.
But still, congratulations, yeah. 第三个是这个。All right, let's check. Where's the check? Yeah. Okay.
Hello, everyone. My name is Zhang. I'm a professor at the Northwestern University, Feinberg School of Medicine. And it's my great honor to present this award to Dr. Dan Yuan from Zhongshan University Cancer Center. And that's a very highly honored award and very competitive. Congratulations.
Thank you so much. Thank you so much. Thanks the USCACA to give this opportunity and for giving this award to me. And it's really a great encouragement for me. And I'm really excited. Thank you so much.
Congratulations, Dr. Lee, to get the travel award, right? It's not easy. Yeah. Say some words.
I would like to thank the USCACA to give me the chance to win this award. And also I want to thank Professor Zhou and Professor Zhu. They give me a lot of support. And thank you.
You guess why I sent this certification to Professor Lee? Because we share the same boss, Professor Zhou.
All right, congratulations. Yeah. Okay, well, congratulations. All right, yeah, thank you. So do we have, come here. All right. We're a little bit pressing of time, so if you could present your slides, please.
Yeah, hello everyone. Thank you, Dr. Yan. And I'm Wang Yan from Ramadan. Now I will take this great opportunity to give a brief summary introduction of our novel ADC, that is a potential best-in-class anti-methicillin ADC. I think most of us know methicillin very well. It's a glycoprotein anchored in cell surface and is overexpressed in several solid tumors, but with limited expression in normal tissue. And our product, RC88, is a first-in-class ADC target methicillin, and with our payload as MMAE. For the linker part, I would like to introduce that is a site-specific cell bridging PY linker. And that linker can optimize antibody structure stability and homogeneous property. With this property, about 70% of RC8 contains DAR of 4 and narrow distribution of DAR species. Also, our RC88 show a high cell binding affinity and ADC killing activity. And most important is that the competition with CA-125, that is the blocking the metastasis of cancer cell. So also the advantage compared to other mesothelin target ADC like Roche, Bayer, or BMS. And in our first in human phase 1/2 study, RC88 demonstrates encouraging efficacy especially in platinum-resistant ovarian cancer. You can see here, mesothelin expression in ovarian cancer is almost 100%, and with strong, moderate to strong intensity. In other solid tumor like lung adenocarcinoma and cervical cancer also show about 50 to 60% of expression. Especially in ovarian cancer, the confirmed overall response is about 40%, compared with standard of care, which is only 12%. That is strong efficacy, I think, even compared with folate receptor ADC that approved early this year. We can see either response rate and DOR are comparable, even stronger than the folate receptor ADC. One thing I want to emphasize is, as Dr. Rao from Pfizer introduced, we believe vedotin as MMAE payload has strong synergy between ICI therapy. It's because the MMAE can induce ICD. So the strong synergy also show in our combination study, which 2 out of 4 PROC patients show confirmed OR. That is promising data too. And we believe mesothelin is a potential best target. The reason here is data from Protein Atlas show that either mRNA expression or IHC expression, we can find that mesothelin has universal strong stain. But compared with CDH6, TROP2, or even folate receptor, I think mesothelin is strong in ovarian, especially in ovarian cancer. And here for this product clinical development, we currently have phase 1 study, monotherapy, or phase 2 study of combination therapy. And also we already started phase 2 study either in China and in the US. Looking forward, we have 7 oncology products. That's strong synergy between ADC and immuno checkpoint inhibitor. So I think that's a good example.
Good, great. Thank you so much. So the reason we had Dr. Wang to present this is going to be used for our panel discussion. So we're going to use this one asset as a panel discussion, as a topic. So now I'm going to invite all the panelists just come here, line up and sit down, and we're going to have the discussion, please. All right. Well, thank you. All right, so you just heard Dr. Wang talking about this ADC with tremendous potential, but really now the company wants to move this compound to overseas, right, and try to develop this for the U.S. market. So we're going to have a discussion really only focus on this single asset and in terms of how they developed, right? Hey, George. So I'm going to just ask questions. We'll just as a sequence, we're sitting here. Jakob, we'll start with you because you are trained as a medical oncologist, so you'll be in drug development. So as soon as you heard about this asset, if Ramjin is going to ask you, now you are managing, you are managing partner for Sofinnova, which is a very well-known VC. And if they want to set up a shot, say, I want to start a company with this asset in the US, are you going to fund me? If yes, why? And if no, why?
Can you hear me? Okay, great. So I think it's a very provocative question, and it's great to think on the spot and nice to be with you all. So first of all, I want to congratulate you because I think this is a very nice molecule. It's a great target. I think the clinical work that's been done here has also been very good from the perspective of doing dose escalation and then also zeroing in on a high interest indication where you could have a path to registration. So I think when we at Sofinnova in particular, when we assess drugs to invest in, we really prefer to invest in companies that have clinical stage assets. So it really checks the box there because there's more de-risking. The further along a program is in the clinic, the more confidence that we can have that it's a safe drug, that it has good pharmacological properties, and that there's a good efficacy sign, maybe even a biomarker, which is also helpful in terms of success. Then we also look at the clinical data, of course, and what we see here is a high response rate, so that's very good in platinum-resistant ovarian cancer. So all of those things point favorably. Now, so that could push us towards a yes. But the things that we also do is we go and we do deeper diligence. So what the deeper diligence for me becomes here is number one, the target indication of ovarian cancer, what is the competitive landscape like in the clinic? So there's the folate receptor alpha ADCs that are already being developed there. We know Elahere is approved, but it's only in very high expressors of folate receptor alpha. The response rates are also modest, so this may be better. But then we also know there are next generation ADCs coming against folate receptor alpha. There's actually a Chinese company called Profound that just did a deal with Genmab, which has an ADC that has a much broader patient population. They're not as connected to very high expression of folate receptor alpha. So that could be a real competitor to you guys. The other thing is we know that Daiichi has a CDH6 ADC as well, and they presented phase 2 data at ESMO this year, which has very high response rates, close to 50% in platinum-resistant ovarian cancer. They're going into phase 3. So as we assess, should we invest here, we have to believe that this drug is going to make an impact in ovarian cancer, given the competitive landscape, what we think is going to get approved. And then we also look, and I think it's very nice that you're looking at other indications like non-small cell lung cancer, but then you have to do your analysis there. We heard about Pfizer's the IB6 ADC. So you have to say, can you be competitive there? And there's mesothelioma as well. So you want to make sure that there's life cycle management. There are other indications to go into as well. So those are all the things that we would consider. So I think from my perspective, hearing this very good story for 3 minutes, I think it's a maybe. There's like that I would invest. Some strong reasons why yes, and also further diligence that needs to be done from my perspective.
Thank you so much. But you did a great job. In 3 minutes, you got VC's interest, although it will take a due diligence to fully flourish. So I'm going to invite you, Dr. Huang, in terms of from your perspective, because if Dr. Huang is going to take this asset to the US and she needs to run global trials, right? And in terms of global trials and assessment of endpoint, the response rate, etc., image is the key, right? You got to read the image, you got to determine whether the patient is responding or not. So you got to use the image to determine what is a PFS, what is a OS. So from merit perspective, could you comment in terms of the challenges in not only logistics, but other aspects of running a clinical trial globally and due to the central reading for images.
Sure, thank you. I've been thinking about it, so I'm going to give a short answer and a long answer. My short answer is this higher merit, because we'll give you a solution for it. Now, here's really the long answer for it. I think that first of all, congratulations on this wonderful drug. I think that Jakob mentioned that there's a lot of opportunity in front of the company. I think this is as we see the excitement as those new treatments come to the marketplace, it's wonderful. You know, for us as well, we kind of share the excitement with sponsor company like yours, right? But when you really start running a clinical trial in the United States, or globally, right, you're going to run into some of the problems that which you may be familiar with or may not be familiar with. You have been running a very successful trial in China already, but when you get to global, start running global trials, there's a number of elements may or may not be the same. Right? And from my perspective as a imaging CRO, our job is to a degree boring, but however, it's important. That is, how can we help you when you run a global trial to standardize data, to how to bring those data together, and to have we call it blind independent central review, a team of clinicians to be able to help you to really give you a objective, a very independent assessment on those patient result outcomes, and eventually bring those information together with you to a FDA or EMA, those a regulatory agency to get it passed. That's what we do. Our job is really try to standardize data, bring the data to the best transparency to you, right? So that if the trial is successful, we want to share with you that the excitement of pass this journey together. That said, right, elements that you're going to run into will be first and foremost, the patient recruitment, right? You as a China company, as we have been working with many Chinese sponsor companies, China speed is very important. You want to really get this drug go through as quickly as you can, right? However, when you deal with different countries, different regulatory requirements, as well as there's a language barrier, the time zone difference, you really need a partner to be able to help you along this line here. So with that said, you really have to do a deep investigation to a degree to both a imaging CRO as well as your CRO partner, because we really become your partner in order to be able to help you. I think those are due diligence will be very important in terms of when you're running a clinical trials.
All right, thank you so much, Dr. Huang. So now we move on to Dr. Liu. So for ADC development, of course, they need to select patients with a target expression, but in addition to histology analysis, what else could you advise the sponsor they need to look out for? Company diagnostic, etc.
Hello, yeah. Thank you so much. And actually, congratulations, Dr. Wang, for the great potential the new ADC drugs. And as the panelists have already discussed that for the ADC that there are a lot of in the market, but for this particular methylene and we as a pathology company, I'm a board certified pathologist. I'm running a GoPath Diagnostics actually in suburban of Chicago, and we also have a booth here. And the one thing that we will do that will suggest that we have done many the Chinese company serving as a central lab. We do like I see that you have done some IHC staining pattern. Of course, that's the initial screening. That when the CRO companies start to recruit the patients that we serving as a central lab, we handle the logistic, receive the samples with from the clinical sites that we do initial screening to identify these patients. And so that's the first level, right? And then we develop the semi-quantitative assay to 1+, 2+, 3+, and then generate the cut points. So that's all the basic. But beyond that, actually, GoPath is also a diagnostic company, is a molecular diagnostics company. We often do other biomarkers to help the clinical monitoring endpoint, and my friend here already mentioned that the imaging as an often common endpoint. But on the molecular level, there are other ways to even precisely measure the endpoint, namely the MRD, the ctDNA measures, along the treatment. So this is something that we can add to the additional the central lab services, and we're very experienced in these areas, and the Profound Bio is using us. We are actually their central lab for Profound Bio. This is recently a big acquisition by GMAP, and we're proud to have been serving Chinese companies recently. It's definitely there's a big uptrend for Chinese company come to United States and come to world, and we'll be glad to help you when needed. Thank you.
Great. So my business partner is signaling me we need to speed up. So Catherine, if this asset is traveling from China to US from a legal perspective, how would you advise them? And then I'll ask you if we have time, if this is to travel the reverse direction from US to China, what other additional consideration you would take, advise them?
So on my flight from New York City to Chicago, Dr. Wang, I was reading your study very carefully. And the passenger sitting next to me asked me, "Are you a doctor?" I said, "No." And he said, "Are you a scientist?" And I said, "No." Then he said, "Why are you reading this stuff? It looks very complicated." And I said, "I help people monetize it. So I want to help you monetize it. I know you are a clinical development VP, but I think to be able to monetize it means to commercialize it and actually bring it to as many patients as possible, right? So that's the goal. So I think I want to make a few points. First of all, I think if you look at the deals, the cross-border biotech deals in the last 12 to 18 months, there's a clear trend of innovations coming out of China being acquired or licensed by big farmers, right? So in the past, I've been an attorney in this country for 22 years. In the past, most of these deals are licensing in from US to China, but nowadays more the other side. And then also acquisitions by multinationals of Chinese biotech assets. So this is a big opportunity for you and your company. And the backdrop of this, I think you understand, it's the poor prospect of the Chinese capital markets, the really tight VC funding in China, as well as the pricing pressure at the back end due to collective bargaining power and the procurement policies, right, of the government. So this is your kind of your situation. So you have to understand your leverage and understand your limitation. Your leverage, as I said, is a very successful scientific breakthrough, but the limitation is you have limited leverage. But on the other hand, multinationals are facing patent cliffs. They also have a lot of dry powder in terms of money they can spend on acquiring innovations out of China. So I think you can really take advantage of the current situation. Just be very careful of the legal and regulatory issues, for example, export control, cross-border data transfers, and also try to avoid geopolitics as much as you can.
Really, the key is talking to an experienced law firm. So, all right, so we gotta move on. So George, you are our seasoned drug developer and the CEO. So you heard Dr. Wang's story. Any comments from your perspective?
I mean, it's wonderful you have a first-in-class, best-in-class potential drug. I think moving outside China actually is the right thing to do because medicine has no boundary. you have to develop a drug for patients, not for one country's patients. So that's wonderful. And all the other consideration of the transaction, you have all the other professionals to help you, such as the legal attorney sit next to you, and also CR, so forth. So don't worry about it. And just thinking through, if you think the things didn't make sense, just stop it. Don't be shy of asking questions. Don't be shy, ask what do you think the compound or your company deserves. And eventually things will come along. So don't worry, congratulations.
All right, good. All right, so that's a perfect conclusion, Melvin. All right, so we're going to invite you. So thank you so much for the panel. Did you hear the case?
I can imagine.
All right. 30 seconds to imagine. 30 seconds to put your imagination here.
So imagination, you know, that's what a BD do, right? You pretend you are expert of everything and you are expert in nothing. Now I put my BD, I try to pitch the idea. I imagine you're talking about a case some China innovative apps want to get out of China and they want to monetize it, and based on quality clinical data with the back of some pretty serious investor like Jakob, right? And some several successful cases like George. So that's what I'm guessing. So a little bit about myself, I'm a BD guy and I do two things. I run in Sensor Trust community. A lot of people in this room are actually my members. I also do a cross-border BD consulting firm, and some of them in the room also my clients. I have been meeting quite a few MNC and also help my friends like Lee have a nice dinner last night. And what I observed, like, you know, exactly like Catherine said right now, you know, I use one word actually from my friend who just left, 边缘 from CUSP. I remember we were both interviewed by an article from Fierce Biotech. And we say, you know, after many years right now, like Chinese biotech asset get out of China isn't more. But Chinese asset get a global price is an exception. Oftentimes they don't get that. And Bean have this fantastic idea called the China discount. So I summarize how I can help my clients to mitigate the China discount. What's the reason they have a China discount? That's where Catherine already laid out clearly. So that's what I'm saying. So just to summarize, I guess, you know, just a little bit shameless plug-in. I think you should let a professional do the professional job of BD. That's it. Thank you.
All right, thank you. Good imagination. All right, well, thank you, panelists. Thank you so much. All right, thanks. So Melvin, it's all yours. We're going to hear about the ASCO breakthrough.
Thank you, thank you. So I'll take 5 minutes, I'm being told, and not more than that, because I don't want to hold everyone back. So again, thank you to, you know, Lian, Minghua, for giving this opportunity for me to come and share about the breakthrough meeting. I've got some slides, if you just go for it. Yeah, makes sense. So I'm the program chair for the meeting this year. It's going to be held in Japan from the 8th to the 10th of August. So a bit of background to the meeting. I think when I talk about a meeting, ASCO Breakthrough, most of you are wondering, what is it all about? Because we've known the ASCO NO meeting, we've known about the ASCO GU meeting, the ASCO GI meeting. So this meeting was essentially an ASCO-sponsored meeting. Its main focus is on health technology, clinical and translational research. So, and the other important thing about this meeting is the only ASCO meeting that's held outside of the United States. So it's actually exclusively held in Asia. The first meeting started in 2019 in Bangkok. Then there was a period where nothing happened because of COVID-19. And last year, it resumed again in Yokohama, Japan. So what ASCO has done is it has gone into a collaboration with JASCO to essentially host this ASCO Breakthrough meeting in Japan for the next 3 years. So this year and next year will be Yokohama, and then subsequently which you'll be up for selection again. The previous program chairs are Professor Tony Mok, who gave a talk earlier, as well as Professor Lilian Siu. So very illustrious, you know, academics, and I have a big shoe to follow as a chair this year. Now, the thing is, of course, the meeting is very different. It's very TED Talk style. It's not your typical didactic lectures. So each talk is only about 10 to 15 minutes long. And there's a breadth of, so it allows us to cover a broad spectrum of topics, which I'll speak about. And a lot of the focus is about translation to the clinic, because a lot of times you think about technology, it sort of hovers around technology, commercialization, and very little focus actually sort of moves into how do you apply this in a diverse ecosystem like Asia Pacific. For example, like China versus Indonesia versus Singapore. So I think that is one of the key tenets of ASCO Breakthrough. And importantly is to allow APAC investigators, innovators, a forum to actually showcase their work. So these are the keynote speakers we have for this year. So as you can imagine, it covers a very broad spectrum. So we have Andrew Tister, who's a clinician and now Chief Tech Officer for AI at Verily. We have Dr. Raffaella Casolini, who is essentially a health policy expert from WHO, and she will speak about cancer policy and equity. And then we also have Professor Shimon Sakaguchi, who will then deep dive and speak exclusively on T-cell and immunotherapy. So these are our three keynote speakers this year, which are very fortunate to have them come to our meeting. And I think this is the center slide. From this, you can appreciate what we really try to cover. So we have the usual precision oncology, AI in the clinic, but the focus really is about what are the new tech, and then we'll also have speakers that will talk about how do you actually implement this in the clinic. And the AI bit will again touch on contemporary techniques or methods like large language models to leveraging large data sets, data sharing, and how do you actually apply that, in practice. Now, we have also decided to go even, more clinical. So this year we'll have 2 new sessions on cancers and robotics and lasers, because health technology is a very important emerging field, right? And it's quite different from AI. And then this will also segue into a section on neoadjuvant therapies. So as you can see in lung cancer, gastric cancers, many cancers, neoadjuvant strategies are coming on board. And this doesn't just include drugs, it includes, technology as well. So it's about, so we're going to have a very broad section on some of these new contemporary issues. But at the same time, it's about keeping our foot on the ground. So we will also have 2 sessions on health economics. And I think that's very important, because as we think about drugs, as you heard in the earlier panel session, it's prohibitive. And some of the drugs just do not have the ability to penetrate the Asia Pacific ecosystem thoroughly. And so then we also have a section on real world evidence and clinical trials. And I think for this section, we're quite pleased to say that we have Dr. Shellen back from NCI, who will actually be chairing the session as well. And basically sharing the insights from both the West as well as from the East. So I think we can all agree that this is the scope of the education session is intended to make it appealing, and that is really, we try to be inclusive. And so we will also have rapid oral sessions. So I'm very pleased. I think one of the things why I came all the way here to pitch this is because this year, when we look through the abstracts, we have 40% increased submissions for abstract. They're all very high quality. We had randomized trials being submitted. And I think one of the most impressive thing was China represented the most number of abstract submissions. So I really wish and urge to have more support from Cisco, Chinese investigators, China institutions to support this meeting. I think this is a very important meeting for us in Asia Pacific to get ASCO's endorsement. I think, we definitely need to be a part of this. And Professor Zhou Zaixin, who's also supported this meeting as well. And I'm very pleased to say that, it's important to showcase the high quality work from Chinese investigators. So then we'll also have the usual networking sessions, focusing on gender equality as well as inclusivity across the different Asia Pacific countries. And so I think I'll end with this note. I think if people ask me what is it about, it is really about everything. Health technology, clinical trials, basic translational research, so long there's relevance to the clinic, and to include everybody, from innovators to industry people. We are probably one of the few education meetings where we actually allow industry people to chair and share their findings. So I think this is a highly valuable and forum where we should really treasure this opportunity. So with that, join me in Japan I wish to have all your support. We still have time to register. I think, do come, experience it, because it's going to be held every year and we can only make it better together. And with that, thank you so much for your time.
Thank you so much. We'll see you in Japan.